Hello everyone, welcome to Apollo Cradle's session on Cradle. Welcome to Apollo Cradle session on pain and fertility and endometriosis, role of laparoscopy. We would like to welcome Dr. Madhuri Vidyashankar P, who is our in-house laparoscopic surgeon. She has specialized in gynec laparoscopic surgery and is credited to perform more than 10,000 laparoscopic surgery. She comes with a vast experience in endometriosis surgery as well. We welcome you, doctor, and we would like you to take the session forward and explain to us what the topic is all about. Thank you.
Thank you, Smriti. And I thank Apollo Cradle for giving me this platform to discuss and educate our people regarding endometriosis, how endometriosis is caused, what are the symptomatology, what are the medications that can be used, whether medication has any role, and when you definitely need a surgery. So this will be the talk for today. Now, endometriosis is much more rampant than we really know about it, especially when you see the infertility clinics. Almost 20 to 30% of the patients can have endometriosis, which leads to difficulty in conceiving. Now this can affect any age group, the adolescents, people in the women in the reproductive age group, and people who can be going for menopause, the women who are going for menopause, and even postmenopause. All the age groups could be affected with endometriosis. Now, adolescent, how do they exactly present? Adolescents can have a lot of pain during their periods. This is the classical symptomatology that goes with the endometriosis, severe pain during endometriosis. And as it progresses, they can have the pain before the periods, during the periods, and even after the periods, a couple of days after the periods as well. So, what we call as a triple dysmenorrhea can be seen in endometriosis. That is all three times, that is before, during, and after the periods, especially when it is associated with another condition called as adenomyosis. So, usually, this endometriosis and adenomyosis will coexist and cause all this kind of pain, the severe pain that goes with the menstruation. And it is not just the pain that it can cause, it can be very asymptomatic. The women may not even know that they have endometriosis, but when they present to fertility clinics, they may be diagnosed with endometriosis, which may be even severe stage with large cysts in the ovaries. Or it can present with new onset of pain. Women who have had no pains at all during their menstruation for say 20, 30 years, but around 40 years of age, they may present with pain during the periods. So this new onset of dysmenorrhea or the pain during periods can again signal towards the presence of endometriosis. So whenever you have excessive pain during your periods, which is not getting subsided with the routine medications that is taken during the periods, or there is difficulty in conception, or new onset pain, or pain during defecation, that is while passing motion you have severe pain, or when the couple are having intimate relationship, so there is severe pain, it is wise for the women to think of endometriosis or to meet the gynecologist to get themselves checked for endometriosis. Smriti?
Yes, doctor.
Smriti,
Doctor.
are you there?
Yes, yes, doctor. Can you hear me?
Yes.
So, doctor, till now we do not have any questions that has come in from the audience. So you can carry on with the session and then we can go forward.
Okay. So, how do the adolescents present? As I told you, it can be, very severe pain during the periods, gradually proceeding further. They can have very severe pain before, during, and after the periods, and it can also be associated with excessive bleeding during the periods as well. Initially, they may not have excessive bleeding, but as the disease progresses, they can have excessive bleeding as well. And these two definitely require some kind of treatment. Now, when they take the routine medications for pain and for excessive bleeding, it is still not controlled. Yes, it is then that they have to really take consultation for definitely diagnosing this endometriosis. Now, the problem with the adolescents, the management of endometriosis in adolescents is, one is the diagnosis can be, it can be really very obscure. The diagnosis on scan may be really difficult to be seen, to be manifest. Okay, so because if it is affecting only the peritoneal endometriosis, that is only the surface of the inner lining of the tummy, it may not be seen on scan. Okay, so it is only on laparoscopy, that is when we put in the scope inside the tummy, that it may be made out. So after the patient presents to us with very severe pain and they are not able to be diagnosed on the scans, the only option that will be left to us is either an MRI, which again may not pick up the peritoneal endometriosis or the subtle endometriosis. So the only option that would be left is a diagnostic laparoscopy. So we usually put in a 5 millimeter scope to see inside the tummy whether there is endometriosis, whether they require treatment for endometriosis. As far as possible, the surgical treatment for endometriosis in adolescents is prolonged. We just delay it as far as possible and try to manage them with medical management, because endometriosis is a recurrent problem. Now, you treat once, you do a surgery once, not that it is going to go forever. It is going to be there till at least the time of menopause, most of the times. So it can keep coming back. So the only way forward is somehow it has to be controlled and it has to be kept in check. Especially the adolescents, they have a long time till they get married and have a, till they plan their conception. Now, once they get married and conceive, it becomes much easier to manage after the pregnancy and the delivery. Till then, it is a very big task to manage the adolescents, because it needs prolonged management, prolonged suppression with either oral contraceptive pills or some hormonal pills that is specifically for the endometriosis, some injections, hormones that are injections specifically for endometriosis, where we suppress the hormones within the body and see that the endometriosis is suppressed. But how long? How long do you do this? If a child develops it around the age of 16, can you manage it till the time she gets married? What if she gets married at around 30, 31, 32, till 35? She may not want to have a child. So it becomes a very lengthy time when the gynecologist will have to manage this endometriosis. So it needs a lot of counseling for the adolescents with respect to the symptomatology, with respect to the recurrence. We have to educate them regarding the recurrence and how they have to be on these medications for a prolonged time so that it is suppressed for a longer time. And also, you plan surgery only when it is really required, unless the patient has very severe pain, the adolescent child, she has very severe pain, or it has ruptured, or it is causing unbearable difficulty during defecation. We do not take them up for laparoscopic surgeries, because once the surgery is done, again, the post-operative management will extend for years together and it becomes very difficult to manage. So, but if they have recurrence before their reproductive age group, before they plan their reproduction, it will require one more surgery. And doing repeated surgeries is not an answer in endometriosis. It is how you manage without surgeries for a long time and assist them in their conception when they really require this conception. That forms our medical management basically. So do the surgery get the surgery done at the right time, so that it helps them for their pain, for their other symptomatology, as well as help them conceive when the time is required, when the conception is required. But in case of those women who come for fertility, for cases of infertility, and it is incidentally diagnosed, or they come with very severe pain, they're also getting treated for infertility. And when we find that they have very severe endometriosis with large endometriotic cysts in the ovary, these are much easier to diagnose on scan as compared to the adolescents. Adolescents very difficult to diagnose, whereas in case of in fertility individuals, so it becomes much easier because we can do a transvaginal scan in the infertile female, and we will be able to diagnose these ovarian cysts much better because of the proximity to the scope of the probe. And also, there are various signs on scan which will enable us to diagnose the severity of the endometriosis as well, the amount of sticking that has happened to the ovary with the surrounding structures, whether the tube, fallopian tube, could be affected. So we can fairly make out even before the surgery the extent of the disease, the severity of the disease, and whether they can conceive without surgery or they require a surgery. It is much easier to diagnose in this cohort of individuals. So when we find endometriosis in women going for fertility, it is mandatory that we have to do a laparoscopic surgery for them, and it helps in diagnosis as well as therapy. What we really require here is that the tubes, the ovaries, the relationship should be well maintained. If it is maintained well, the fertility chances would be good, and also the egg quality will be good when the endometriosis is not very severe. So we assess all these things on laparoscopy, and when there are adhesions, it is released, the cysts within the ovary are removed, and it's all made favorable for pregnancy to happen through either IUI or through IVF, depending on the severity of the condition. Now, what is very important in surgery for endometriosis in those patients who are going for fertility is that the ovarian reserve, or what we call the number of eggs in the ovary, have to be conserved. Okay, so even the fertility specialist can give pregnancy even with one egg, with two eggs. So it is very important for us, the endoscopic surgeons, to see that we retain even single follicle that we encounter during the procedure. So it is a very skilled surgery, very fine surgery, and we make sure that the ovarian reserve is maintained absolutely during this endometriosis surgery, which is a very difficult task. And also, the first surgery is the best surgery in case of endometriosis. Repeated surgery is not the thing to be done. Okay, so first surgery, once it is done, we plan a cycle or two of suppression of the with the hormones, and third cycle we usually manage them with either IUI or IVF or natural conception if everything looks good inside. But what is important, what I want to convey is that once a good surgery is done, it should be immediately followed with a pregnancy. Now, earlier the conception happens, the recurrence risk is very less. Now, in case the recurrence happens after surgery, so you go for a surgery again. So, multiple surgeries will reduce the chance of pregnancy. So, what I want to convey is that planning a surgery, yes, a good surgery with wherein you can conserve the ovarian reserve very well, followed by immediate conception is the way forward. Because once conception happens, the endometriosis becomes very simple to manage. Once the patient conceives and delivers, the ovaries are absolutely inert. It can be managed very well with intrauterine devices. After delivery, we place something called as Mirena or the Indian available intrauterine devices which release the medications. So this can be placed for 5 years at a row. So 5 years, and again you place it for another 5 years. So for the next 5 to 10 years after delivery, it should not be difficult to manage endometriosis. So what I can say for the people, for the individuals in the reproductive age group is, you have infertility, you have endometriosis, yes, you still have good chances of conception. Go for a good surgery once it is indicated. Okay, following surgery, plan your conception immediately. This I would like to highlight again. Plan your conception immediately. Don't delay it for months together because recurrence chances are very, very high. Plan your conception, then after conception it becomes extremely easy for us to maintain the endometriosis, to keep it suppressed for say 5, 10, 15 years very conveniently. And those individuals who are in, now this was about the reproductive age group, now those individuals who are in the perimenopausal age group, that is say around 40 years and above, those who are maybe in another 5 years, 7 years or 10 years, they could be having their menopause. So how do they present? They can have new onset pain during their periods. Earlier, they may not have had anything. They may had one delivery or two deliveries. But sometime around 40 years or 42, 43 years, they may start having very severe lower abdominal pain during the periods, okay, which can be there during periods, before periods, and after periods as well. And it can be excruciating. It may debilitate the individuals to such an extent that those 3 to 5 days or 7 days of the periods, they may not be able to carry out their daily chores. So it becomes very important for us to diagnose these cases and give them a complete therapy. So usually these individuals will have an associated adenomyosis as well. So endometriosis and adenomyosis will coexist in these individuals who have already delivered, and it can be really very painful for them. So this again, the diagnosis becomes very simple on the ultrasound, transvaginal ultrasound. We diagnose, and the conservative management for these individuals can be a Mirena or the intrauterine device placement, which can again manage for the next 5 years or so. Meanwhile, they can most of them go in for menopause. So, conservative management is also possible in these individuals. And if they are very much close to their menopause, we may even manage with just hormones for, say, 6 months to 1 year at the most, which are safe for them, of course. And we could still avoid a surgery for them. But those patients who have very severe pain, not tolerable, not tolerating the medical management at all, yes, a surgery would be indicated. And in these individuals, we plan removal of the uterus and removal of the ovaries as well, because leaving behind the ovaries is again a risk for recurrence. So they do definitely well after removal of the uterus and the ovaries, and they need definitely follow up post the surgery yearly once with the scan and other modalities. Can there be cancer in endometriosis? Yes, very, very rarely. They can be associated with endometrial cancers or even endometrioid cancers in the ovaries, which is extremely rare. So for this, we do a test called a CA-125 whenever we see this endometriosis. Now, this gives us an indication whether they can be associated cancers within this endometriosis. Also, the scan findings and the Doppler findings that are done routinely for these individuals gives us an idea whether it can be anything suspicious. Now, if it is anything suspicious, we take adequate precautions and see that if at all they require an open surgery, that would be planned. Now, this is overall about the adolescents, endometriosis in the adolescents, in the reproductive age group, and in the perimenopausal age group. There is certainly treatment for every individual who is suffering from endometriosis. For the pain they are suffering from endometriosis, it can be excruciating, and it requires a prolonged therapy, prolonged counseling, and cooperation between the surgeon, between the gynecologist, and the patients. Smriti?
Yes, doctor. So we have a few questions. So first is like you spoke about, menopause time for females, and then the bleeding or pain happening. So there is a person who's asked that my mom has faced this issue. She's almost in her age of menopause. Is it say and she's having pain? How to control it? Should she consult a doctor?
Yes, yes, she will have to consult, especially when the pain is, new onset pain, or earlier they were all fine, but off late they have been having pain around this perimenopausal age group. It's very important to rule out the fibroids within the uterus. They can have inside the cavity the fibroids, or endometriosis or adenomyosis. These are very common around this age group. So it is very essential that they consult your relative consults the doctor, gets a transvaginal scan or the necessary diagnostic modalities done, check for the endometrium, the myometrium, and the other things that is essential, and see what is required to be done.
Thank you, doctor. So, is this mostly common among women who have already conceived?
No, no, it can happen even in the adolescents. That is, young girls, who have just had their menarche, and who are 12, 13, 14, 15. As young as that age, they can still have endometriosis. And as old as, 50 also can have endometriosis. It can affect any age groups.
Okay. So, are there any steps that people can take beforehand to prevent this pain or heavy bleeding?
See, what one of the theories of the why this endometriosis happens is it is menstrual reflux. That is, the menstrual bleeding, what goes out, also goes into the tummy or into the pelvis. Okay, and this can be aided by the if intercourse happens during the menstruation. So this is one thing that can be avoided. Menstruation, when the woman has menstruation, intercourse should best be avoided. Apart from this, there is no other modality or a precaution that could be taken to prevent this endometriosis. It is early
Oh,
diagnosis and treatment that could help the individuals.
okay. Thank you, doctor. So, is this can this pain or this problem in the menstrual cycle be genetically transmitted?
Yes, it can be. It can run in families. The endometriosis, adenomyosis. We have seen families. Family members. Almost, I think I've treated almost some 18 to 20 women of a single family. Extended family. Most of them having endometriosis and adenomyosis. Okay, so it can definitely run in families.
Okay. So this is another question. Whenever there is a change in environment or food, so I have not high. The person has heavy bleeding and pain. Should I get it checked?
Yes, whenever there is heavy bleeding, when I say it can be like more than 3 days, and you're changing many more pads than what you're changing every day, or if it is lasting for the more number of days, and anything abnormal from what you had earlier, along with severe cramps during the periods, yes, it's time to get yourself checked. Meet a gynecologist, get a scan done. If everything is good, yes, that's absolutely fine. But if you find something, early diagnosis will definitely help and goes a long way in controlling this disease.
Okay. Thank you so much, doctor. One person is asked, will the surgery have any negative side effect? Are there any risks involved in the surgery?
Yes. See, it's a very complex surgery. The fact that, because of the fact that, endometriosis is something, what happens inside the tummy is that there is the uterus, the two ovaries on either sides, and the two fallopian tubes. Now, behind the uterus, you have the intestines, and in front of the uterus, you have the urinary bladder. This endometriosis is such a problem wherein it can attract or it can stick to all the surrounding structures. So the intestines, the tubes, the ovaries, the uterus, everything can be totally stuck. So when we try to do the laparoscopy, it becomes very essential for us to push aside or say completely dissect out this intestines onto sides and then do the surgery. The ureters, the urinary bladder, can everything be stuck around. So it's not a simple surgery. It's a little complex surgery, yes, of course. But laparoscopically, wonderful job can be done with respect to the fertility surgeries as well as with respect to the hysterectomy. Now it's so advanced laparoscopically that very safely the surgeries can be done. Okay, but it is very essential that it has to be done with from the surgeons who are very skilled in this. and
Right, doctor.
also and also what complications can they face is that because of the proximity to the intestines, the intestinal injury can happen. It can, so we take all the precautions, pre-operatively we give them a thorough bowel preparation so that even if there is injury during the surgery, we'll be able to handle it at the same time as the surgery. We'll be able to suture it or take care whatever is required during the surgery itself. If there is a bladder injury, that could be repaired. The ureter is the tube that carries the urine from the kidney to the urinary bladder. That can be affected in the endometriosis disease as well. So if that requires repair, yes, that may have to be done. So we will be equipped and prepared before the surgery for all these eventualities. So it is that preparation that is required. So otherwise, it is it should be a well planned surgery, and most surgeons will be able to do it best. Gynec laparoscopic surgeons.
That's great to hear, doctor. The next question is, what is the success rate of laparoscopy surgery?
Yes, see, success, if you measure it in terms of pain, if you measure it in terms of fertility, if you measure it in terms of no recurrence, you can measure it in these three things. With respect to pain, yes, it can give you certainly very good pain. Pain can be totally removed, but these are all, it is for a very short time. Okay, so what we require is after the surgery, it is the management of with the medications that is required, the fertility that is required. Okay, so that will help them give a prolonged resolution of these symptoms. So it is not just the surgery, surgery planned with post-operative care and post-operative fertility. That is together will give them very good relief from the pain, relief from fertility issues, and also see that the long term recurrence will be less. So it involves overall management and for a prolonged time.
Okay, I think the next question, I think most of the doctors are being asked these days. So, if I'm undergoing a laparoscopy surgery, how long should I wait before taking my COVID vaccination second dose?
Yeah, you can take it on your time. Surgery has got nothing to do with it. You can continue your vaccinations as scheduled.
Okay. So the last question is, doctor, do mental health also affect these factors like pain or heavy bleeding or the change in a periodical menstrual cycle?
Certainly, yes. Certainly, yes. The stress has got a very significant bearing on the menstrual cycles, the regularity of the menstrual cycles, the duration of menstrual cycles, and also the flow, the amount of flow that happens. It can be absolutely linked. It can also affect the fertility. So it is very important that the mental balance or the status should be absolutely good when when all these things are there. And it is important that a counseling, the discussion with the doctor helps to a great level in allaying their anxiety as well.
Okay, that's great, doctor. That's all for the questions from the audience. Is there anything else that you would like to cover in the topic?
I think that's it. So the main problem here is fertility. Those individuals going for fertility, women, I would like to suggest that get the first surgery should be the best surgery. Follow the surgery immediately with pregnancy. Okay, don't delay your pregnancy, no matter what has been suggested to you, whether it is IUI, IVF, or a natural conception, whatever be it, you should conceive at the earliest. Okay, and then post pregnancy and delivery, you should follow it up with the prolonged treatment as suggested, that is the intrauterine devices. So with this care, you can manage your endometriosis without affecting your pain and any other condition to you for a very very long time, at least till your menopause.
Doctor, there's one last question that has come in. So, person has asked that if PCOD or PCOS, will it be affected if we get a surgery done? Like, will it increase in any form or will it affect the fertility process in any way?
See, PCOD is a totally different subject. In polycystic ovaries, it's not like endometriosis. It's not a recurrent problem. In polycystic ovaries, if they have been advised to go for a surgery, what is called as the ovarian drilling, yes, it is done once. Ovarian drilling, if indicated. Of late we have literally reduced the amount of ovarian drilling numbers. Because we can as well manage with the hormones, the gonadotropins and the other medications during the fertility treatment. So there are very, very limited cases of PCOD drilling that we do of late. Okay, but endometriosis is a different thing wherein we definitely have to do the surgery before planning this conception. And even if they're going undergoing surgery for polycystic ovaries, the surgeon has to be, he must know how many holes have to be done, how many drills have to be done, so that they don't go into unnecessary ovarian failure. Yes, I'm sure the surgeons who will be doing it will know it well.
Thank you, doctor. Thank you so much for an insight about the entire topic. I hope females, especially, have understood the fact that when it's a pain or it's a heavy bleeding, it's not normal, and they should immediately, consult the doctor and talk to them and get something done about it. And same with people who are trying to conceive. So, thank you so much for this insightful session. We hope to get a session and learn from you about more other topics very soon. Thank you so much, Doctor, for joining us today.
Thank you, Smriti.